Good morning, everybody. How's it going? Today I came to talk to you about the surgical fire safety program and what's changed or what's happening. And unfortunately, a lot of organizations kind of curtailed or kind of postponed a lot of the training from last year. So many of you have not had like a deep dive surgical fire safety training program for now 2 years. So one of the things we want to continue to do is build some muscle memory. And kind of, we've been through this a number of times, and, we really haven't come up with any new ways to set our patients on fire. Hopefully we don't do that. But, fire is fire. The risks are still there. We got to continue to work on it and build that muscle memory. So what do I mean by that? It's like, well, you do surgical fire safety training once a year. And my wife's an educator, and she tells me, well, how often, I ask her, how often do you need to do something to develop a competency, to develop muscle memory? And she says, 30 times a month. That's once a day you need to be doing something to develop a muscle memory competency. That means where you don't need to be thinking consciously about the skill that you're doing. So the things we do every day, those are the things we build muscle memory. Well, you're not responding to fires every day, so that's why we do at least annual fire safety training when we get actually into the ORs and the different specialty care areas. Take the time to practice the fire suppression, even if you've been like, I've had people like, oh, I've been doing this for 10 years. I don't need to do that anymore. Like, you've done it once a year for 10 years. Want me to hold this? Is that better? Oh, good. Yeah, I know I got competing with a fan above my head here. But anyway, if you've been doing the fire suppression once a year for 10 years, you've not come anywhere near a muscle memory. So that's one of our goals this year. And so we're going to be talking about surgical fire safety, the risks, the hazards, how to mitigate them, how could we identify those high-risk cases in advance, what are our mitigation strategies to prevent a fire from happening on our patient, and then what to do if it does happen. So we're going to talk about response procedures in a number of different scenarios. So we've got a lot of material to cover between now and 11 a.m. Just kidding. We're going to be finished by 8. That's a joke. So couple scenarios, couple examples. Fire emergencies are real in healthcare organizations, and these are some of the more dramatic ones. The one on the top left, that was Mount Sinai Hospital in Manhattan a number of years ago. And they had a fire in an elevator shaft, a significant amount of smoke that went up and infiltrated a number of floors, and they ended up having to evacuate about 400 patients. Not to the outside, not to the parking lot, not to the streets of New York City, but just horizontally on the same floor past the fire doors to another area. But what they didn't anticipate was what is in the other area. And so they were taking some higher acuity patients and ending up in some real low acuity or even non-acuity areas. And so it was a little problematic. The other one here was up in Canada. That was a rooftop fire, a heating, ventilation, air conditioning unit, a air handling unit on the roof that caught fire. And unfortunately, what was happening right below it was their neonatal intensive care unit. And they were really worried about fire infiltrating down through the roof, so they did a vertical evacuation of a large number of very critical infants coming down the stairs into lower floors. And that was very challenging. So when we talk about evacuations, how we're going to move these folks, and when we design our fire procedures, these are the things we take into account. So let's kind of get back to the basics here with the fire procedures, with RACE. We haven't come up with any new ways to say RACE. Rescue, activate the alarm, close doors, contain and confine, and make an evacuation decision. In our surgical areas, we're going to talk about 3 different scenarios. And the first one is going to be a fire honoring the patient, and then we're going to have like a fire that happens maybe in an operating room or another critical care area. Maybe a piece of equipment on fire, something filling the area, the room with smoke. And then the third is our open suited areas, such as our same-day surgery, surgical daycares, PACU recovery spaces, holding areas, where there aren't doors around the patient room to the hallway. So we don't have a defend-and-play strategy there. So we're going to go through these different scenarios here, starting with our operating room. So OR procedure room fires. So we have fire extinguishers in those spaces. You have a water mist fire extinguisher that actually exists in the space, so we don't have to leave the space to go somewhere else to find it. And that's primarily for a drape fire, something that's on a piece of equipment fire. And you might say, what a water mist fire extinguisher for a piece of equipment on fire. That doesn't seem to make sense. Is this guy crazy? Nope, it's a deionized water that's in that canister, and it comes out as a mist, so it does not conduct electricity. And that is actually the preferred fire extinguisher, either that or a carbon dioxide, but those are the ones you have for an equipment fire. And the nice thing about it is it doesn't disrupt the environment that you're in. So if you look around this room in the back corner there's one of those red fire extinguishers, an ABC dry chemical fire extinguisher. That powder in those, and that's kind of like what we have throughout the rest of the hospital, probably similar to one you have at home. The ammonium phosphate-based powder that's in those fire extinguishers is an irritant to your eyes, throat, nose, lungs, and if you were to use that inside your operating room or procedure room, that would make everyone in there very miserable very quickly and probably force an evacuation faster than the smoke condition occurring in there. So our crucial actions for a fire in there, in that space, remove anyone in immediate danger? Well, maybe. We're not just going to automatically rush out of the operating room. And typically, if it's a fire that's on or in the patient, the rescue or the remove means we have to put the fire out. If it's a fire on or in a piece of equipment, how quickly can we evacuate out of our OR? And that's why it's a maybe, because it's not something we can just pick up and walk and run right out of there. If you're in the middle of a surgical procedure, that's going to take minutes. And so you need to have and be enabled to be able to try to knock down that fire on a piece of equipment very quickly. And that's why the National Fire Protection Association and our firm and many other firms like ours that do surgical fire safety training teach and promote the best practice of having that fire extinguisher actually mounted on the wall inside your OR. It, believe it or not, is not a requirement in the standard yet. But right now it's not a requirement. It's a best practice. But most of our clients actually have them mounted in the operating room, which is where we want them to be. We need to activate the alarm, definitely. Anytime there's an actual fire, flame, sparks, smoke, activate your fire alarm. You'd be surprised how many times we hear, well, we didn't have an actual flame fire, we just had like a fire. There was a little bit of smoke and we put it out and then we didn't think we needed to activate the fire alarm. And no, you must activate the fire alarm, you must have the fire department respond. There are 28 states in the United States that are mandated to report any fire in the hospital to the state fire marshal's office. The Commonwealth of Massachusetts is one of those states. So, easiest thing, pull the alarm. Even if you had a fire and the fire is out, pull the alarm, have the fire department respond, have them tell you it's no longer an emergency. They will call their fire marshal who will do their report, who will get that report up to the state fire marshal's office, and then you are covered. But we definitely want to pull that fire alarm. Evacuation. If we need to evacuate, we need to know what the roles are, and we're going to be practicing these in our mini drills today. But everybody in the operating room has a role, and it's important that we all stay in our lane and work together. Communication is the key. So anesthesia, need to disconnect all our physiological monitoring, maintain the airway, maintain oxygenation and ventilation of the patient as necessary. Our circulator, you have three important jobs. You're the communicator, you're the air traffic controller, you are the key, you are the connection from that OR to your charge nurse in the outside world. But when you make those communications, and so it's your job to make sure that you communicate that you're in a code red situation or you have a fire situation, you need to communicate that out to your desk and to your charge nurse. Make sure they pull the alarm and call the emergency number. And yes, that responsibility vests with you. So if you call out to the desk, call your charge nurse, say, hey, we have a fire in the OR, and I need to activate. I need you to activate the alarm. I need you to call the emergency number. If they don't do it, you're still responsible to do it. So that's important you understand that. Scrub person and surgeon, you have to figure out how you're going to make it safe to travel through the hallway to get to your evacuation location. And then support staff, other staff that are in the area, helping it, making sure the hallways are clear. Last person out of the room, be kind, close the door. If we're leaving, if we're evacuating out of an OR, we're doing that because there's something bad going on in there that is making it untenable to stay inside. And that's typically a significant smoke condition. Well, if we're leaving, we want to make sure that smoke condition stays there. So make sure the door closes on the way out. Shutting down medical gases. Typically, it's a charge nurse or somebody that's in a clinical role in a department. But coming out of an operating room, that responsibility is for anesthesia provider. The anesthesia provider is not the one reaching into the wall and pulling the valves. right? They're hands-on with the patient going to the evacuation location. So who's pulling the valves? Somebody else that's going to be staying behind in the area, but no one is going to touch those valves until anesthesia says it's safe to do it. Closing remaining doors. So this is our OR corridors. Most of our doors close all the time anyway. They're access control doors. But really important, making sure that OR door to that room where the fire is closed so it contains all that smoke. No new cases should begin. And I can tell you story after story of where there have been cases that were about to start when there was a fire emergency or the fire alarm went off and they were like, it's probably a drill. Maybe we should just wait. And this one in particular happened in a hospital in Connecticut a couple years ago. Within 30 seconds, the charge nurse came into the OR and was like, pack up, we're getting out of here. Turns out there was a very significant fire and a heater in the hallway right outside the OR. And because they had not started, they were about to start. The surgeon had the scalpel in his hand. And he was like, let's just wait a minute. And then they came in. If he had started, they would have been now had the patient open, it would have taken a lot longer to prepare the patient. They were able to just quickly put the table to wheels and disconnect what they needed to disconnect, and they rolled right out of there. And that hallway was starting to get smoke in it. So really important, no new cases begin until we're given an all clear. And evacuate remaining rooms is directed by the person in charge. Do we always just automatically evacuate every OR? No, we can defend in place. We're in a closed, sealed room, positive pressure environment. If the fire alarm goes off, we just keep our doors closed, we defend in place unless somebody from outside the room tells us that the situation's getting worse and we need to leave. So that's typically the charge nurse working with engineering and the fire department when they get there. They'll give us that information and inform us of what we need to do. So everyone's got a role there. If we do need to evacuate, we need to work together. But we need to know where our evacuation locations are. Where's going to be the best place to go? And a little more on that in just a while. So depending on where we're working, if you're working in ORs 1 through 6, and there's very specific reasons why these are your designated evacuation locations. Nothing is arbitrary in fire procedures. So we've taken the time when we designed the fire procedures to look and see. Look at your floor plans, look and see where the fire and the smoke barrier walls are. Look and see what's on the same floor. We don't want you to have to force you to go up or down the staircase with your patient. So it's a horizontal evacuation past a fire smoke barrier to get to another clinical space. So if I'm coming out of an OR, I'm not going to send you to a conference room because there's nothing medical there to continue the care of your patient. I want to get you to another care area that is similar in acuity to where you're coming from. So your ORs can go to your ICU, CCU space, endoscopy, C2 or B2 unit. C-section ORs can go to any of your LDRP rooms, 405 to 412. And you'll see on the floor plans I'm going to show you in a minute why this makes sense. PACU holding short stay can go over to B2, C2 unit or ICU, CCU, and your cath lab to the A5 unit. And it's following those three kind of important rules. Same floor, so horizontal, past a smoke or fire barrier, and to another unit or area that has a similar or like acuity level. So here's your floors, your floor with your operating rooms and your PACU and your short stay holding area. And you can see all these here, they're all in the same space. These little red lines, those represent your barrier walls. The blue lines here and the red lines. So blue lines typically represent a fire barrier and the red lines typically represent a smoke barrier. I'm not going to get into all the life safety code differences between the two. Just understand that either one of those, if you get beyond them, you're going to be safe from any smoke that could migrate in the ceiling towards you. And that's really what we're looking to do, is get you to a safe spot. So all of our ORs, PACU, short stay holding area, they all reside in the same smoke compartment, is what we call it. So in an evacuation, I need to get you to a different smoke compartment or beyond that wall. And here's that wall at the end of the hallway here. And that's why this is your ICU, CCU space over here. That's why that is your designated evacuation location, your primary from coming out of any one of these spaces. There are many hospitals where coming out of an OR, we go to the PACU because it's in a different compartment. Not the case here. Looking at, and your endo is over here as well. So you can see your endoscopy units, in recovery is in the same space with B2, but you can come down over here to C2 unit, and you're beyond one of these walls. Same thing here with your C-section OR, all right? And their LDR rooms here, 1 through 4, in the same space. So we want to go over here to these rooms over here. They're in a different space. See some patterns here. Cath labs, 1 and 2, barrier wall around them, going over here to the A5 unit. And then also over here, your IR rooms, same thing, 2-hour fire barrier separation here, so IR can come over here towards the ED. And so following those 3 kind of rules. So what is it about these walls, and how do I know they work? Well, number 1, they have to be inspected annually. So someone's got to go into the ceiling, above the ceiling tiles, and just doing a visual kind of inspection on these walls to make sure that they're intact. And what do I mean by intact? Well, yeah, you call in vendors occasionally to go into the ceiling to run fix a pipe, or maintenance facilities is in the ceiling fixing pipes or running additional wiring. You might call a vendor in to run additional computer wires. I was in a facility just earlier this week, and I said, we need to go and inspect some of your smoke barriers. And the maintenance said, they're fine, you don't need to go. And I'm like, no, we really need to get a ladder and just pop a couple ceiling tiles and look. And lo and behold, the first ceiling tile I popped off, and I looked up, and there was a big old 1/2-inch hole drilled right through the sheetrock wall with about 4 computer wires running right through it. And he was like, oh, when did that happen? I didn't even know. I'm like, you got to follow your vendors. You got to follow after your vendors and make sure that they caulk up those holes with the fireproofing material. And he's like, well, how serious is that hole through the wall? I said, a hole the size of a pencil. Fire, smoke on one side of that wall. The size of the space on one side will equalize the smoke, will equalize going through a pencil-sized hole, filling the space on the other side of the same size space in 3 minutes and 40 seconds. That's how serious. A penetration the size of a pencil hole or pen hole through a wall is very serious in a smoke barrier. So we got to make sure we get in there and we check these things and make sure they're all sealed and caulked. So what are we talking about? This is that caulking material that you can see here in this picture versus something like this where you've got a hole drilled through the concrete wall here and a pipe going through, but there's all this space around the pipe. So we want to make sure that we caulk all that material, that you're going to a space that you're truly going to be safe in, that smoke is not going to get you there. The fire's not going to probably is more than likely, is not going to come out of the room that it starts in. And it's hard to get people to buy into that, but when you're sprinkler protected, the sprinklers will activate by heat. It'll put a lot of water down on the fire, and it'll knock the fire down where it started. It's the smoke that spreads. And when you hear this in the news all the time, what kills people mostly in a fire? Smoke inhalation. You hear it all in the news, right? There was a 2-alarm fire on Main Street last night. 10 people went to the hospital with smoke inhalation. You hear that? That's almost the mantra that you hear all the time. It's the smoke. It's that toxic smoke. That's what kills people in a fire, so that's what we're trying to escape from. If you're not a believer that these fire doors actually work, so this picture and the next picture hopefully will change your mind. This is a hospital that has cross-corridor fire doors right here. All right, there was a fire in the hallway. On the other side of those doors, there was a piece of equipment, probably the little I call them vital signs on a stick, right? It's the vital sign machine that's on a post on wheels, but there's something on there, plugs in, it needs to plug in to keep something charged, or maybe it was one of the computer on wheels, whatever it was. It was something that was plugged into the wall. It shorted out, it caught on fire, it was a pretty hot fire, flames, it set off the sprinkler in the hallway and also triggered the smoke detector. There were patients in these rooms down here on either side that defended in place here throughout this fire, and they were perfectly fine. And this is what the other side of the doors look like. That's pretty dramatic. And those doors stayed closed the whole time, and that barrier wall stayed intact the whole time. They did put a piece of plywood up here to shore up the wall, because the wall did have some damage from the fire that was there. And they did that temporarily until the vendor got in there to fix it and replace the sheetrock. But the walls and the doors, they actually work. They really do work to keep people safe in the building. And staying in the building is just something completely counterintuitive to what we were taught when we were growing up. Everybody remembers doing fire drills when you were really little in school. The bells went off, and what did we do? Everybody got up, and we marched outside. Can we do that in a hospital? Nah, it's completely impractical. Especially in a surgical environment, your patients are, they're anesthetized and they're sedated, and that you can't just get them up and walk them out. And even if they were awake, many of them are non-ambulatory because of the procedures they're about to have or just had. So we have to have the environment built in such a way that we can stay inside of it. So talk about fire and PACU day surgery, ICU areas that have kind of bayed concepts or even places that have what appear to be rooms, but they have like the glass kind of doors, the breakaway doors. A lot of ICUs have those, a lot of emergency departments have those, and it gives kind of the false sense of security that you're actually in a room and you can just close the door. Those doors are really sound barriers, and that's it. There's really no fire or smoke protection afforded by those whatsoever. And in terms of the fire code and fire procedures, they're the equivalent of having a curtain around you. So it's important to know that. But these spaces that are bays are separated by curtains, you can't defend in place in there. So if you have any sort of a fire that's generating any kind of smoke condition, your threshold for evacuating the entire space is very low. And so that changes things for us, because if we're evacuating one, we're evacuating all. And that means we need a lot of hands very quickly. So if you ever hear a fire alarm going off, and then you have a code red situation in your PACU or your holding area or your ICU or any place like that, you need to mobilize people very quickly, because if it is a true emergency with a smoke condition, you're going to need a lot of hands on deck very quickly to afford that evacuation. Again, following our RACE procedure, all right, we're going to remove anyone in immediate danger, which is certainly the person or patient that's closest to where the fire is occurring. Get the fire alarm activated by pulling it down. Closing any doors, we don't have that many doors. It's curtains, so really not a whole lot to do there. And again, our threshold for evacuation very low. Fire extinguishers in the PACU space are typically the ABC fire extinguishers, the all-purpose fire extinguishers. So what does the ABC stand for anyway? So that is really the different types of fires that we can put out with a fire extinguisher. So a type A, Class A fire extinguisher is a fire that is good for, or a fire extinguisher good for a fire that burns and creates ashes. So think A, ashes, stuff you find in a trash can, a waste paper basket. Surgical drapes would be or a cloth, a gown, sheets, towels. That would be an A-type fire. A B-type fire is a flammable liquid of some kind, things that bubble and boil. So gasoline, propane, grease, oil. Another B-type fire would be your alcohol-based prep solution as the fuel. That would be, because it's a liquid. And then a C-type fire is an electrical fire, circuitry or electrical current. And so these ABC fire extinguishers, they're good for all three types. The problem is unintended consequences. The ABC fire extinguisher is a dry powder chemical, as I mentioned before, and it's an irritant to the eyes, throat, nose, and lungs. And so if you're going to use it in a space like a PACU, let's say you have a monitor fire in a PACU, and you start evacuating the first patient out, somebody grabs that fire extinguisher, pull, aim, squeeze, and sweep is how you use it. You pull the pin out, you aim it, you start discharging this powder, and now you have this cloud of ammonium phosphate-based powder everywhere. Is that going to be dangerous for your patients to be breathing that in? Is it going to be dangerous for us to be breathing it in? Potentially, yes. Potentially, yes. So you have to be thinking about what are the unintended consequences by using that in the space if it's occupied. And so there's our big space there, and this is what it looks like. I mean, it's very quickly creates this cloud of powder that gets everywhere. And if you're in a confined space like a PACU or holding area, that is going to consume the space very quickly. You're not going to be able to avoid getting that in your eyes or breathing that in. If you want to hear more stories or vignettes about bad things that have happened using a ammonium phosphate-based powder fire extinguisher, come see me after the lecture. I can tell you about a story of a gentleman that lived at a nursing home outside of the Chicago area a number of years ago. Very bad outcome. Order of evacuation. And a lot of times we'll ask in the PACU, well, who do you think we should go first? And a lot of times people are thinking, especially clinical folks are thinking acuity. Let's get the high acuity patient out first, and the low acuities can probably self-evacuate. In a fire emergency, yes, acuity counts, but proximity to the risk is more important. So the patient that's right there, if it's a fire and a piece of equipment in their bay, they go first. The next people that go are the two adjacent bays, and then so on and so forth. Yes, we're going to need hands for our non-ambulatory patients. If you have family members or visitors there that are able-bodied, patients on a stretcher, have them help you. Do what you need to do to be able to move these patients as quickly as possible. All right. Defend in place. Does this apply to the PACU? No, it doesn't. You can't stay. You got to go. Again, we're pulled the fire alarm, ORs, no new cases begin. Everyone's got to go into this holding pattern, getting doors closed. And especially if you're in an evacuation location, so it's also important to know, hey, the space that I work in, am I a listed evacuation location for someplace else? And I can remember years ago working, I was a hospital-based paramedic, worked out of the emergency department, and we were on the ground floor. And the fire alarm would go off, and we'd stop for a second, we'd listen to hear where it's coming from. Oh, it's 3rd floor, 4th floor, or above. Be like, it's like 4 floors above me, whatever. Go back to doing whatever I was doing. And now I know, it's really important, thinking back, it's really important to listen to where that alarm is coming from and ask yourself, are we an evacuation location for that location where the alarm is coming from? Could that, if there was a real fire, if this is a real fire occurring there, could it impact me where I am right now? And if the answer is yes or maybe, then think about, okay, what do we need to do to prepare? Are we ready? Are we ready for patients to come through the door being evacuated to us? And if we're not, what do we need to do to get ready? So those are the things we should be asking ourselves, especially if I'm the person in charge, if I'm the charge nurse or I'm a person in charge in that space or in that area. So fire on or in the patient. So we've talked about fire in the OR on a piece of equipment. We've talked about fire in a PACU, open bay, suited space. Let's talk now about fire on or in the patient scenario. So first thing to do, we're going to remove anyone in immediate danger. Really? Well, if the fire is on or in the patient, the danger is on them. So rescue becomes put the fire out. What are we yelling out? So if I'm in the OR and I'm the first person that sees the fire emergency in the OR, what am I yelling out to alert the entire team? Fire what? I know you know this because I made you all yell it 2 years ago. Now you're going to make me yell, you're going to make you yell it again. All right. So what are we yelling? We're yelling, fire, shut off the gases. Fire, shut off the gases. If we're in the OR, right? Because we use oxygen a lot. And if we're using oxygen a lot in a closed, confined space, over time, what are we creating? An oxygen-enriched atmosphere. What does fire love? An oxygen-enriched atmosphere. So if we have any kind of a fire emergency, we yell, fire, shut off the gases. And that is instruction for anesthesia to shut the machine off and stop the flow of med gases to the patient. So to get us all uncomfortable at the same time, because it is uncomfortable yelling in the hospital, we are all going to yell, fire, shut off the gases at the count of 3. Ready? 1, 2, 3. Very good. That was more of a mantra, not a yell, but I'll accept it. I'll take it. So, fire, shut off the gases. What actions are we performing? Well, those that are right at the table going to have to put the fire out. Or if it's an airway fire, that's more anesthesia's job to put that out. Circulators need to get our crucial actions of communications going. Now, we need to get communication out to the desk and to our charge nurse, that we need to get the fire alarm pulled, and we need to get the emergency number called. If you are a charge nurse or ever cover as a charge nurse, a designee, so to speak, and the fire alarm goes off and you hear that it says that it's in your OR suite or OR area, or somebody at the desk calls you and says, hey, we have an OR, we have a fire in OR, either 1 through whatever OR it is, stop what you're doing and get to that OR. This is one of those fail points. When we talk about building muscle memory, we also look at what are the continued pain points that we see when we do fire drills across the country. And I can't tell you how many surgical fire drills that I've done where the charge nurse never shows up at the OR. Now, most of the time it's like, well, I'm really busy and I knew you guys were doing a drill. Not acceptable. The drill, whatever you do during the drill is what you're solidifying into your muscle memory. And so if you allow yourself to not do the correct actions in a drill, that's what your body, your muscle memory is going to remember in the real emergency. Because then the fire alarm will go off the next day, and what are you going to tell yourself? Subconsciously. Are we doing another drill? I don't think I need to go. You need to do the correct actions. It's like sports practice. When you show up for sports practice, and I tell my kids this all the time, when they were participating on sports teams, and they'd be like, oh, I'm really tired. Do I really need to go to practice? I'm like, yeah, of course you need to go to practice. And bring your A game to practice. Dad, it's just practice. I'm saving my energy for the real game. And practice like it's game day. Practice like it's game day. Practice when that fire alarm goes off and you know it's a drill. Practice like it's the real thing. The more you practice like it's the real thing, you will build that muscle memory so when the real emergency happens, you will react the correct way. So we got to get those communications out. Charge nurse needs to get to the room, make contact with the circulator nurse, find out what's going on in the room and what they need. All right, so whoever's at the desk and takes that call. And if it's close, you might just open the door and yell, code red in room whatever down the hallway. Does it have to be a phone call? No. But we need to make sure that the fire alarm gets pulled down and that the emergency number gets called. And remember, this responsibility vests with the circulator. So if they don't do it from the desk, if you don't hear that alarm going off in 15 to 30 seconds, option A, call back the desk. Hey, you really need to pull the fire alarm down. Or 2, go and do it yourself. Option A, option B. All right? Fire suppression. Whoever's at the table, at the patient, we need to put the fire out. If the fire is on or in the patient, we need to put the fire out. That's going to be the rescue. All right? This more than likely will not be an evacuation. Fire on or in the patient very rarely results in actual evacuation of the OR because we put it out very quickly. But you have to know what the tools are, the order of operations, and the techniques to put that fire out safely. So, airway fires. Fire shut off the gases. Anesthesia providers, they're typically going to be the first one that sees it because they're going to see the smoke coming out of the circuit. Or the surgeon might know because if they're doing an upper neck, chest kind of a surgery with a laser, this is typically how these fires happen. If it's an endotracheal tube fire, quick shot with the laser, it transects the trachea, goes through the endotracheal tube, and that's your heat source that hits your tube, which is the fuel, which has 100% oxygen going down the middle of it. Those are all 3 ingredients I need to make a fire. And now I have a jet engine shooting flame down the trachea out the end of the endotracheal tube. Anesthesia's got to manage that. Pull the circuit, stop the flow of oxygen down the tube. Pull the inflator bulb, rip the inflator bulb off the endotracheal tube, extubate the patient. Couple cc's of saline in a flush, cool the trachea down, reestablish the airway, do a surgical cricothyrotomy if you need to, but you need to reestablish that airway, and treat that injury. These airway fires are the ones that have the highest. These surgical fires have the highest mortality, morbidity, obviously, because it's in the airway. There are a number of cases of where that we've actually used in our training a number of years ago that the families actually allowed us to speak, just advocating for surgical fire safety where there was unfortunate bad outcomes. Thought that was no, it's just a picture there. You can see the flame on the end coming out the endotracheal, and that's what it'll look like inside the trachea, and you can imagine the soft tissue damage that happens from that. So surgical site fire, skin, hair, sponges, gauze, could be in the oral cavity. There are lots of different fuels in those environments. So how are we managing those? Saline. I know you set it up every time. When you're setting up your case, you always have a bowl of saline on the field, typically on the back table or on the Mayo stand. But that is your number one go-to fire suppression instrument. Having your bowls, whichever size bowl you use, having your saline poured into that bowl. If you've got bulb syringes, big size bulb syringes, making sure that these are filled with saline, put on the side, right there on your back table, so that you just reach for it. It's never more than an arm's length away. That's what you can reach for. Squirt that saline, whether you're going into the oral cavity, whether you're going to a body cavity. If it's a larger fire that might be on the drapes, you can just take the entire bowl and just completely saturate the field if you have to. But the saline is what you're always going to reach for first. If that doesn't work, or if you're talking about a drape fire, if it's extending onto the drapes, all right, try to remove the burning material, but you throw the saline first. If that's still burning, grab that surgical towel and do the sweeping technique. So I'm going to try to move this over here. We'll do our little demonstration. So it's going to be hard to do a two-handed demonstration and hold a mic at the same time. So I'm going to do my best, though. So if this was our operating room table, thank you so much. I'm going to throw my mask on just for this part. So if this is our operating room table here, and we have our patient right here, all right, remember, what am I yelling? Fire, shut off the gases. We take our saline, we throw our saline, fire's still burning on the drapes. Take a surgical towel, does it not need to be wet? Patient's head is here, so I want to create a barrier to protect the patient's head. Pull the surgical towel down over, sweep out the oxygen towards the patient's feet, towards the foot of the table. Keep my barrier in place, pull the towel back so I can check to make sure the fire is out, and then I come off the patient. All right, so one more time, full speed. I kind of went very slow there to kind of show you the technique, but it doesn't require a lot of speed. It requires good technique. So fire, shut off the gases, just like that. And I can put a fire out very quickly. Now, if I had a fire, even if it was a small flame on a gauze or a sponge, and I put it out with saline, do I still need to activate the procedures and pull the fire alarm? Yes, good answer. All right, who is my volunteer? She got voluntold, actually, before the lecture started. So hopefully you were watching, all right? I'm going to come on this side. So just hold it up from the corners, just like that. All right. This corner hand to right there. That hand, pull it down, sweep, and come back. Good. Excellent. Have you ever done that before?
Nope.
Never done that before. Thank you so much. All right. All right. Now I just need to find my clicker. I always do this. There it goes. It's hiding there. Let me get this out of the way. Thank you. Our surgical fire suppression. So remember, saline, sweeping. If that was a full drape fire, after we sweep the fire out, we knock it down. The drapes come off of the patient to the floor. Folks at the table, so our surgeon, scrub tech, anesthesia provider, reassess the patient, treat the patient if there's any injury, look for any extension of fire. So you want to just check the sheet, the chuck that's around and underneath the patient, see if anything else is on fire. If there is, put more saline. Circulator, come over and assess the drape that's on the floor. And if it's still smoldering, grab your fire extinguisher. You got that water mist fire extinguisher, the big white one with the baby blue stripes around it. Grab that, pull the pin, aim, squeeze, sweep, and saturate that drape that's on the floor. Make sure that it is extinguished. The whole idea is if we do this fast enough, we might be able to prevent having to evacuate the OR. Wouldn't that be a good thing? All right, because evacuating the OR, if we don't do this quick enough and we actually have a smoke condition in the OR, if I've got embers floating around the room, we might have to evacuate, and that's where we're going to practice when we actually go into the ORs. All right, so we make that evacuation decision. In the OR, the decision to evacuate is typically made between the surgeon and anesthesia provider. It's not the circulator's decision, it's not the charge nurse's decision, it's not the scrub tech's decision. So physician and anesthesia together, talking together. Ultimately, the physician of record has to put a note in the chart that the decision was made to evacuate, and so they'll be culpable for that decision. So they want to make that a good, informed decision. Do we have to go? What are the implications? What are the risks, benefits of leaving versus staying? Obviously, if you have a smoke condition in the OR, you need to leave. So if the fire is out, and there's no more threat for any increased fire. Let's say it's a small fire, but it's a little smoky or smelly in there. Could you just come out and go to another OR? Absolutely, as long as it's not an OR that's connected through a shared substerile room. You could go to another OR. If it's a piece of equipment fire or something that's bigger in the wall or in a lamp or something that's getting worse and it's escalating, then you need to come out and go to your true evacuation location, which is going to be down the hall past the fire or smoke barrier into your ICU space. I get it, it's not ideal. So if we're leaving, we have to think, what do we need to take with us? Is the patient still open? Am I going to need to close the patient? What am I bringing with us over there? And there, you'd be surprised how many folks are like, well, we'll just throw a surgical towel over everything on the back table, and we'll roll that whole back table with us all the way down the hall. You don't have enough hands to do that. Moving the patient on the OR table, you have the 4 people around the table, and you need to go with whatever you're taking, you're putting on the table with the patient. You don't have enough hands to roll your Bovie machine and your back table and your Mayo stand and taking everything with you. You know, there's no pack mules carrying all this stuff down the hall for you. Once we get over there, if we need to, we can request some additional equipment. So if we need to get we need to get respiratory and a ventilator to continue to vent the patient. Maybe if we need to continue, if the patient's still bleeding, maybe we need to open the patient back up and do some cautery. So maybe I need to have a Bovie machine brought over there. We'll grab whatever instruments you have that's on the Mayo or on the back table in a tray or whatever you have, put them on the patient, cover them with a sterile surgical towel, cover the patient, pack the wound, pull them together with an IO band, whatever you need to do to make it safe to move that patient through the hallway. Maybe you're just going to that other space and you're just going to wait in that space, make sure monitor the patient, keep them safe until we can get back into an OR to open the patient back up and finish our surgery. So lots of different options there. So let's talk a little bit about, we're going to finish up talking about the risks and prevention. So I mentioned the 3 different ingredients to make a fire. In the fire service, refer to this as the fire triangle. It's a way we kind of have a way to kind of think about the 3 different ingredients that are needed to have a fire. You need to have fuel, the thing that's burning. You need oxygen, room air is enough, and you need to have a heat source of some kind. So in the surgical environment, our fuels are all those things that can burn. So our sheets, our towels, our gauzes, sponges, hair, skin, alcohol-based prep solutions, those are all fuels. All right? Oxygen, room air, 21%. And then if we're using an open source of oxygen on the patient, we're creating an oxygen-enriched atmosphere when we get above 30%. Makes those fuels burn a lot faster and a lot brighter, a lot hotter in the presence of a heat source. And the heat sources that we use are a cautery, our Bovie machines. 70% of surgical fires initiated by the cautery. We also have fiber optic light cords that account for about 20% of surgical fires, and 10% of surgical fires attributed to the use of laser. So those are the top 3 heat sources that we need to be concerned about and putting them together in our fire triangle. The concept of the fire triangle is that each side of the triangle represents one of those elements. And if I keep any one of those elements away, so I have an incomplete triangle, then you don't have fire, you don't have combustion. If the fire happens, so all 3 sides of the triangle come together, and I have fire, fire suppression is how do I remove one of those elements to put the fire out. So people are very familiar with, the fire department. What do? They put water on a fire. So what does that do? The water takes the heat, converts it to steam, and pulls the heat away. So you're removing the heat, because that's really the only thing you can do on a very large fire. It's very hard to block off the oxygen supply when you have a very large fire. Small fire, like that on the patient, is very easy to surround and smother that fire and block off the oxygen supply. So when she covered with the surgical towel and she swept it, what she was doing was she was blocking off the oxygen supply to that fire. So that was what made the fire go out. So when we talk about the risk, and this is right in the NFPA 99, which is the Healthcare Fire Code, Chapter 15, which we have consultants that sit on that technical subcommittee and help write this fire code and rewrite it every iteration. It's about every 5 years or so a new version comes out. And right in Chapter 15, and now it's, I believe, 16, they changed it. Looking up there, the new version coming out is going to be Chapter 16. It's all about the surgical fire environment and surgical fire safety. But that is what points us and tells us that we have to do this surgical fire risk assessment before every case during the timeout. And that's our opportunity to identify if we have a high-risk case. So we ask a series of questions, and you can see on the right here, this is right from the AORN Fire Risk Assessment Toolkit, the series of questions. Some organizations will combine question E with question D, so they kind of use it all as one. It's basically the question about heat sources. But the question is, what's the location of the procedure? Above Is the procedure site above the xiphoid? Because if it's above the xiphoid, we're getting close to the airway where we deliver the oxygen. Next question is, am I using an open source of oxygen, a cannular mask? Next question, am I using, I think there's another question. No, the first question is the alcohol-based PrEP. So I'm a little out of order there. But oxygen, alcohol-based PrEP solution. Am I using an alcohol-based PrEP solution? If you answer out of these questions, if you answer 3 or more a yes, then you've just identified a high-risk case for a fire to happen. So that's great. That's the first half of prevention. So identifying the high-risk case. The real prevention comes from what are you changing in your practice now to prevent the fire from happening now that you know you're doing a high-risk case for fire. And this is where there's still some pain points across the country, things that we hear. So I'll share with you some. And one of the biggest ones is around the alcohol-based PrEP solution. It's taken a long time, and there's a really good reason. Anybody in here an infection control practitioner? Because I am not one, but I have friends that are. And infection control practitioners will tell you there's a real good reason why we use the alcohol-based PrEP, because it's really good at preventing the infection in the skin post-surgery. And that was a big patient safety initiative a number of years ago. And that was why the industry came up with this solution, alcohol-based PrEP. But just like with the fire extinguisher that has the powder in it, the alcohol-based PrEP has unintended consequences. You fix one problem, you create another problem. And the problem that we created was an increase in surgical fires across the country, to the point that 10 years ago, we were having about 15 surgical fires a week in the United States. 15 a week. We're down to about 3. But then, there's only 28 states that are mandated to report them, so that might be 5. That means it's still 1 a day. That means by 5 o'clock today, 6 o'clock today, the end of your surgical day for elective procedures, a patient will have been burned in an operating room somewhere in the United States. That is still unacceptable to me. And so we kind of are continuing on this mission of getting this out there. And I spend time talking about this because it's still a pain point. We've accepted the 3-minute dry time. Everyone knows it, we're timing it, we put the PrEP on, we let it dry, 3 minutes, we time it, and then we pull the drapes over. So why are we still having fires? Why are we still having fires with alcohol-based PrEP? And you all know the answer, I just can't hear you saying it. No, we let it dry 3 minutes. Pooling. And there's another word I want to hear. Hair. Hair. Still getting it in the hair. I'm not saying you guys do. Maybe you don't. If it's a pain point, if somebody wants to tell me on the side privately, we can figure out a way to try to address it. But this is the pain point that I'm still hearing across the country. The hair. We're still getting alcohol-based PrEP into the hairline. Whether it's we're doing a craniotomy and we're still using alcohol-based PrEP on the head, or we're doing shoulder surgery and we're not clipping the axilla hair and we're saturating it with alcohol-based PrEP, or I'm doing a complete knee replacement and I'm prepping from the groin all the way to the ankle, but I'm only clipping from mid-thigh to mid-calf, so I'm getting hair wet with alcohol-based PrEP. The alcohol-based PrEP will dry in 3 minutes on hairless skin. It will not be dry in 3 minutes if it gets into the hair. And that's one of the reasons why we're still having surgical fires. So, I'll jump off my soapbox on that now. How does oxygen affect the fire? And I talked about that. So in an oxygen-rich atmosphere, we get this increased combustion, faster, hotter, and things will burn in the direction of our oxygen source, which is one of the reasons why we want to get that oxygen shut down at the time when the fire happens. We need to, how can we lower the chance of oxygen? Maybe we can just use less. Maybe there are certain cases where we automatically know we're going to be using a closed system, so we're going to be putting the patient under general anesthesia and putting an LMA or an endotracheal tube in, rather than trying to use an open source of oxygen. If it's a case where we need to use an open source of oxygen, then maybe we just use less as long as we keep the saturation safe between 94 and 99%. And if that's not an option, then maybe we need to spin the gas down before the surgeon brings cautery in. Our goal is we do not want to be using one of those 3 heat sources in an oxygen-rich atmosphere. That's where danger happens. So could also consider, suction or some kind of way to scavenge oxygen away from the area. I've heard in EP labs, in cath labs, especially when they're doing pacemaker insertions, patients on an open source of oxygen, when they're getting ready to cauterize, the anesthesia shuts the oxygen down and then holds a rigid tip suction in the area just to scavenge away any remaining oxygen from the environment to make sure that they're not cauterizing in an oxygen-rich atmosphere around the patient. One of the important features or kind of characteristics of oxygen that we need to understand is that it's heavier than air. So when a patient is laying supine on the operating room table and they're being delivered an open source of oxygen, that oxygen is not dissipating up in the environment. It is settling down around them. So over time, they will develop kind of this halo of this oxygen-rich atmosphere that will grow in size. And that's why it's really important that when we're draping the patient, we drape and tent in such a way they're not tucked so that oxygen can flow off of the patient and get to the floor and go down. All right, we don't want it to kind of collect, but it can pool around them. The use of incise drapes, those sticky drapes, so that if oxygen does creep underneath the patient, underneath the drapes, it won't get up into our surgical site where we don't want it to collect. Different types of equipment, so laser-safe endotracheal tubes or heat-resistive tubing, tinted solutions, things like that. I already talked about our alcohol-based prep, and it says right on the packaging, wet hair is flammable, and it only should be applied to hairless skin. All of our different alcohol-based prep solutions, they have 70+% alcohol in them, so they are very flammable, and it says it right on the packaging there. Alternate solution, betadine. It's a water-based, it's non-flammable. But if you take the fire safety hat off and put on the infection control hat, you need an even longer dry time with betadine so that it's an effective germicide. Don't ask me what the dry time is. I've heard 5 minutes or longer, but you should check with the infection control folks on that. There's right on the packaging, right there, 3-minute dry minutes on hairless skin. So it says it right on the packaging. All right, so we need to do better at following the packaging. Laser as a heat source. Really, it's all about the eye protection and keeping the patient safe, having eye protection available. Fiber optic lights. Anybody ever seen a little hole on a drape like that? Show of hands. Who's seen a little kind of burr, a little bullet hole in a drape? A number of people have seen those. That is the result of a fiber optic light cord being set down while it's activated, or it's set down and it gets activated. It takes about 4 seconds to burn a hole through a drape and a fiber optic light cord. What it didn't find was an oxygen-rich atmosphere on the other side to make that drape take off and become a big fire. So use those as a learning opportunity. How did it happen? How can we prevent that from happening again? We talked about our cautery. Really making sure that it's never set down on the drapes. When it's not in use, it gets put into the plastic holster. Use your scrub tack. Scrub tack, take that if you have to. Make sure it gets in the holster. It never gets set down onto the drapes. All right, different types of cautery that we have, monopolar versus bipolar, but just understand, even though one is considered safer than the other, they both develop heat at the tip. All right, so they both, if they're set down, can cause a drape fire, can cause a fire on a drape. Other common fuel sources, gauzes, drapes, prep solutions, these are all of our different fuels. What's our mitigation strategies for preventing these things? Well, our gauzes and sponge, make sure they stay moistened with saline. A gauze that's slightly moistened with saline will not catch on fire if it comes in contact with a heat source. A dry gauze comes in contact with our cautery, it's going to catch on fire. Even in a non-oxygen, in a 21% room air, it's going to catch on fire. So we're going to wrap up here, right at the end of our time. Couple questions to see how well we did this morning. Question number 1, is it okay to bring an ABC fire extinguisher into an active OR and discharge it? Yes or no? No, very good. And that's why we have the water mist fire extinguisher mounted inside the OR. When evacuating a PACU short stay, who is first to be evacuated? Closest to the fire, most mobile, least mobile, or everyone for themselves? Closest to the fire, excellent. 3, where is the OR's primary evacuation site should they need to evacuate due to a fire emergency? I hope I'm on vacation this day. Now, where is it? ICU, excellent. And question 4, who can make a determination to evacuate other OR's procedural areas in a fire emergency? So not necessarily the fire where it started, and the answer is D. It's going to be a collaborative kind of effort, a communication between all of the above. So our fire response team, nursing leadership charge nurse, and our fire department incident commander. So with that, I'll be up here for a few minutes. I know most of you need to get going to your ORs to get things ready, but if you have questions, I'm happy to take your questions up front.